This is the second part of the anesthesia for transposition of the great arteries. After talking about the arterial switch, we will talk about the atrial switch or the Mustard's operation. It is used to treat ccTGA with deconditioned LV. As we said before, the left ventricle, the left ventricular wall muscles become thinner and unable to withstand the aortic pressure after the arterial switch. So in this case, if the patient is older than 2 months or so, we can't do an arterial switch operation, so we leave the arteries in place. The left ventricle is faced with the pulmonary artery, and we switch the venous return, the atrial switch operation. So we switch the venous return. The blood coming from the vena cava will pass to the left ventricle through trousers-like baffle or a pantaloon-like baffle to the left ventricle and then to the pulmonaries, and then the oxygenated blood comes from the pulmonary veins and passes around the baffle and falls into the right ventricle and then is pumped to the aorta. As a palliative procedure with non-closure or fenestrated closure of the VSD in patient with TGA and VSD with advanced pulmonary vascular occlusive disease. Surgical, the interatrial septum is excised to create a large ASD. So we remove the interatrial septum, and then a baffle is made, autologous, pericardium or synthetic, is used to redirect the systemic and pulmonary venous blood flow to the left ventricle and the right ventricle respectively. Anesthetic goals to maintain duct patency before the operation. If the patient is duct dependent, to maintain cardiac output, to maintain pulmonary vascular resistance less than systemic vascular resistance, maintain good hydration for lung and body perfusion, and to decrease viscosity. Induction of anesthesia. The presence of an IV peripheral cannula is highly recommended for good hydration, to give inotropes or vasopressors if needed, and to induce anesthesia intravenously. And the rest is like the arterial switch operation. The same monitoring: midazolam, ketamine, atropine, sevoflurane, or if no IV cannula, fentanyl, muscle relaxant. Intubation by oral non-cuffed endotracheal tube. Leak test is done. It is expected that the leak may increase after bypass and MUF due to resolving of airway edema. The temperature probe is inserted orally. Arterial line is inserted in the femoral, radial, or axillary axis. Usually the temperature probe is not inserted orally, it is inserted nasally, because these patients are usually old enough or large enough to be able to receive a TE probe in their esophagus. So we can use TE. Usually we can use a TE in these patients. So in this case, we will not insert the temperature probe orally, but we will insert it nasally to the nasopharynx. Central line. Check the vitality of the limbs after cannulation. Maintenance: maintain the same anesthetic goals. Further doses of fentanyl are needed. Morphine infusion till transfer to ICU. Muscle laxants and SIVO less than 1 MAC. Mechanism of CNS injury are multifactorial: preoperative brain malformations, perioperative hypoxia, ischemia, emboli, low cardiac output states, bypass, deep hypothermic circulatory arrest. The use of cerebral oximetry to measure regional saturation is recommended. Heparin, ACT, tranexamic acid. Separation for bypass, the same as we have said before. No significant bleeding, adequate perfusion time, rewarming, deairing, good biventricular function, no ischemia. on ECG, no arrhythmias, heart rate at least 140, unless the patient is much older. Mirror nor add pacemaker wires. At separation of, we give calcium, maintain systolic blood pressure, blood and blood products. The MAF is usually done to increase hematocrit, to consolidate clotting factors and platelets, to increase blood pressure, reduce pulmonary vascular resistance, and remove inflammatory mediators. It has been shown to decrease bleeding significantly. TE post, as we said, that TE can be used in these patients. Biventricular function, baffle leak at suture lines. So we examine the left and right atria, and we examine the baffle inside them, and then we check the suture lines, whether there is a leak at the suture lines, and we check for the baffle stenosis that causes systemic or pulmonary venous congestion. Stenosis can be caused by sutures that narrow part of the baffle, and that may narrow the SVC, the IVC. And sometimes a loose baffle may sometimes the baffle, if it is loose and redundant, they may get close to each other, causing narrowing of the bloodstream, for example, from the pulmonary veins to the tricuspid. Sometimes the SVC and the IVC baffles are too narrow, so that there is an elasing across. Sometimes the SVC is narrowed and sometimes the IVC is narrowed, and usually this is because of either suture lines that are too narrow, the position of the suturing too narrow, or the baffles are too redundant, or one of the atria is distended, so causing the baffle to put pressure on the other chamber, causing acceleration of the blood. Long-term complications, RV failure. This is important because the right ventricle, the anatomy of the right ventricle, the direction of the muscle fibers, the conduction system they were not created to withstand the aortic pressure. So if we use the RV for the systemic blood, for the systemic circulation, the direction of the fibers and the direction of the Purkinje fibers, they are not suitable for this function. So later, the right ventricle fails, maybe in the second or third decade of life, they fail. But the left ventricle, the muscle fibers are circular and others are diagonal. The Purkinje fibers are distributed evenly, so that contractility is a twist-like contractility from apex to base. So the left ventricle is designed to withstand the high aortic pressure, but the right ventricle is not. So RV failure, baffle issues such as leak or stenosis, intractable atrial arrhythmias due to the suturing in the atria, and maybe there is some dilatations. So this causes intractable atrial arrhythmias. 6, sinus syndrome, scarring of the SA node, atrial flutter, scarring around the baffle sutures. Okay, now we will go through the operations done to correct subvalvular pulmonary stenosis or LVOT stenosis in TGA. We have the Rastelli, the REV, and the Nikaidoh operations. They are used to treat TGA with an uncorrectable LVOT obstruction. This is the Rastelli operation. This is the Rastelli. The Rastelli, in the Rastelli there is a pulmonary stenosis, and there is a VSD that is committed to the outflow. So in this case we can put a baffle here to direct blood from the left ventricle to the aorta through the VSD, ignoring the pulmonary stenosis or even pulmonary atresia. So we ignore the LVOT stenosis or the pulmonary stenosis, and the blood passes from the left atrium, left ventricle to the aorta through the VSD, and then blood in the right ventricle is shunted to the pulmonary using a conduit, external conduit. This conduit can be synthetic or can be a tissue like it can be a homograft or freestyle. The VSD is closed with a patch placed diagonally in such a way that the left ventricle is in continuity with the aorta. Pulmonary artery is ligated at the level of the pulmonary valve. An RV2 APA conduit is placed. The conduit can be an aortic or pulmonary homograft with a polytetrafluoroethylene graft extension. It can also be a contegra graft, a valved contegra graft, which is better than a hollow tube. The RAV procedure, it is short for réparation à l'étage ventriculaire. This avoids the use of a conduit. This is the RAV with the Lecomte maneuver. In this case, we do the same like the Rastelli. We put a baffle to direct blood from the left ventricle to the aorta, and then instead of putting a synthetic graft from the right ventricle to the pulmonaries, we pull down the pulmonaries and attach the main pulmonary artery directly to the right ventricle, and we may put an RVOT patch like this. With the Lecomte maneuver is that we transect the ascending aorta and to be able to advance anteriorly the right pulmonary artery. So we pass the pulmonaries from behind the aorta to in front of the aorta. This is Lecomte maneuver. This is to avoid extracardiac conduit, because this conduit is synthetic and it does not grow with the patient. But the RAV procedure, the advantage is that this RVOT or this anatomy, it grows with the patient, and we do not need to put the patient does not need to be on anticoagulation or antiplatelets. So it has better outcomes on the long run, but it is technically difficult because pulling the pulmonary arteries anteriorly may put tension on the pulmonaries and may put tension on the heart itself. The apex may be pulled outwards. That may compromise the anatomy, the hemodynamics a little. So the RAV procedure is used to avoid the use of a conduit. Otherwise, a double root switch, the Nikaidoh operation, can be done. It therefore achieves LV to aorta and RV to pulmonary artery conduit while bypassing the LVOT. So this is the Nikaidoh operation. So instead of doing an arterial switch, instead of switching the arteries, we switch the LVOT with the RVOT. So we take the pulmonary stenosis and put it on the RV, so the RV becomes stenotic, and we take the LVOT, we take the aorta with the RVOT, and put it on the LV. So we open the path from the left ventricle to the aorta, and then we transect the LVOT and the RVOT. We connect the aorta with the LVOT like this. So the LV to aorta, the path is not stenotic, and then the pulmonary, we do the Comte procedure. We transect the ascending aorta, we pull the pulmonaries anteriorly, and then we connect the pulmonaries this way. In this case, there is also a free pulmonary gauge. We remove the pulmonary valve, the stenotic pulmonary valve. So the result in the Nikaidoh operation and in the RAV operation is that the pulmonaries are directly connected to the RV, and there is a free pulmonary gauge. This free pulmonary gauge can be addressed later when the patient reaches teenage or puberty or later. It can be surgically addressed by putting a homograft or a freestyle, or otherwise transcatheter pulmonary valve implantation can be done. Anesthetic goals, the same like we have said before. Also, these cases may be old enough to have a TE inserted. All the same. Separation from bypass. TE post, biventricular function, no residual VSD, laminar flow across the LVOT to the aortic baffle, and laminar flow across the RV to the PA conduit. These two should be checked. Now we will talk about the ccTGA and the LTGA. The ccTGA is short for congenitally corrected TGA. The LTGA refers to the rotation, the lever rotation of the great arteries. The ccTGA is an AV discordance, VA discordance. Sometimes it's called ventricular inversion, so that the left atrium opens into the right ventricle and then to the aorta, and the right atrium opens into the left ventricle and then to the pulmonaries. So right atrium, left ventricle, pulmonaries. The RV and tricuspid valve are systemic, and the LV and mitral valve are pulmonary. The pathophysiology, the double discordance should render the circulation normal, so no intervention is needed, theoretically. However, or usually, not theoretically, usually no intervention is needed. However, in up to 98% of cases, there are other congenital anomalies with variable severity. So usually, these other anomalies are the anomalies that are addressed. Mostly VSDs, so we need to close the VSDs. So a ccTGA with a VSD is like a VSD, the same pathology. An LVOT obstruction, it is like an left-sided obstructive lesion. Tricuspid valve anomalies. Symptoms range from cyanosis to pulmonary congestion and heart failure according to the anomalies. Arrhythmias and conduction anomalies due to abnormal AV node positioning. This can be found. Later in life, by the 5th decade, the RV failure and tricuspid regurg occur because the right ventricle and tricuspid valve are anatomically ill-suited to carry systemic pressures. As we said before in the mustard operation. Surgical options according to which ventricle is the post-repair systemic ventricle. So, if the RV, if eventually the RV remains the systemic ventricle, so this is a classical or physiological repair in which we keep the ccTGA and we correct the other anomalies. Later in life, the RV failure occurs. Sometimes we may need tricuspid valve repair or replacement because the tricuspid valve anatomy is ill suited to withstand the high pressures of the systemic circulation. We may need multi-site pacing to improve the function. So this is, in short, we just address the concomitant anomalies, but we do not address the ccTGA. Systemic LV, this is the anatomical repair in which we correct the ccTGA, usually after a band to train the left ventricle. So we do a mustard and a switch. So it is a double switch procedure. It is a very long and an ultra major procedure in which we do a mustard and the switch operation in a neonate or a very young infant. So avoiding this double switch operation may be logical, so that we leave the patient with the ccTGA. We just close a VSD or an ASD and leave him to grow old. Maybe he will suffer an RV failure later in life by the third or the fourth decade, but doing this operation, this double switch operation, may be dangerous for these patients. But if this double switch procedure succeeds, so on the long run it would be better. If there is stenosis, so if there is LVT obstruction, we do a mustard and Rastelli operation, which is also an ultra major operation. Systemic LV and RV, if we go through the path of the single ventricle, we do a Fontaine procedure, Fontaine operation. So this is again the diagram that was shown before in the first lecture. This is the ccTGA. If no associated anomalies, we either expect in management to do nothing with the risk of RV failure later in life, or we do a double switch operation. If associated anomalies, if the anomalies are unrepairable, so we do a univentricular repair, a Fontaine procedure, and we go through the path of a single ventricle. If biventricular repair is possible, so we either do a physiological repair, in which we correct the anomalies, the associated anomalies, and leave the ccTGA, or we address the ccTGA. If there is no pulmonary stenosis, we do a double switch operation, or a double switch operation after training the left ventricle with a band. If there is a pulmonary stenosis or atresia, we go through the mustard Rastelli operation. Sending is like a mustard operation. It's an atrial switch operation. So this is a double switch. We do a mustard operation and an arterial switch. Preoperative anesthetic considerations are failure and tricuspid regurg, associated anomalies, and prior pulmonary band. Postoperative anesthetic considerations: LV failure, deconditioned LV, conduction abnormalities, coagulopathies like lung, kidney injury due to very long bypass time. It's an ultra major operation. Thank you very much.